Thank you very much for the kind introduction, and thank you all for being here. Second day, hopefully lots of food for thought. And I'll be picking up from the prior speaker at a time when your brain is not enough of a parachute and doesn't keep you afloat with just catching and checking and changing. Not that easy for many patients, and often we need support to actually do that. And that support can be the wind of family members, but also the wind of medications. And we'll be talking about targeted psychopharmacology of major depressive disorders. We're obviously all very grateful to Viatris to sponsor this event, and whatever I'm talking about are slides I put together, and it's not necessarily the view of the company. However, I'm being paid for also talking to you, you know that, but we can hopefully also at the end engage in a very nice interaction and discussion, bringing the data alive so that you can take something home to also use with your patients. This is my further disclosure information. I'm fortunate to work with a number of companies that still operate in the brain. Many have left because it's so difficult to bring new medications into our hands, and we're grateful to those who still put mental health up on their agenda, and Viatris is certainly one of those companies. What do I want to cover with you in the next 35 minutes or so to catch us up on time? First of all, you know a lot about major depressive disorder. It's happening a lot in life. About 17%, 6 to 7 people in their life will have a depressive episode. That's a lot. And then that can have a lot of ripple down effects in terms of functionality. So what do we need to do? We need to treat it. Clearly, when it's severe enough, symptoms that become a syndrome, that become a disorder, when there's either distress or dysfunction. And the guidelines I'll go over clearly say start with psychotherapy, but add on pharmacology when psychotherapy is not enough or not available. And then we'll talk on 2 options and put them into the context of other treatment options. That's venlafaxine and sertraline, 2 of the prototypes of either SSRI or SNRI treatment. And then we put our heads together a little bit. When would I choose one over the other? And what do the data show? Some of the older data, but also some new analyses that you may not have seen. And then we'll finish up with the take-home message. Wherever you go in the world, antidepressants are part of the core pharmacological treatment basket that we have available, and we have a lot of them available. Fortunately, also a lot that are pretty safe. We've graduated, obviously, from the typical or first-generation tricyclic antidepressants to more of the second and third generation antidepressants, and thereby we've been able to reduce side effects quite a bit. So SSRIs and SNRIs are among the primary treatments that are suggested based on the data we have, whereas older TCAs, tricyclics, or MAO inhibitors are more second line. Some patients may still need them, especially for OCD. Clomipramine is still one of the most powerful agents we have. When SSRIs alone don't work, we may have to go there. I think for depression, we very rarely go now to the older treatments, at least I do. I would then augment, for example, with an atypical antipsychotic that is also approved, or maybe with some mood-stabilizing agents. There's a question whether 2 antidepressants together could be better than 1. If you do that, obviously, they should have different pharmacologic mechanisms. And so maybe meanzarine, mirtazapine, so the alpha-2 agonists that increase noradrenaline in a different way might be one way of augmenting SSRIs and SNRIs. And going away from Northern America, you can also see that other areas in the world put the antidepressants, especially SSRIs and SNRIs, up on top. Now, what's very important, and you know that from whatever treatment target you have, but maybe also wherever you go in life, earlier is better than later. Doing something fully is better than just doing it partially. Same thing in depression. We have data after data that when you have long delays until treatment and the illness can nest itself in the brain and also in the lives of patients, and when you still leave a little bit of the fire alive, then the outcome is worse. Because obviously the smoldering illness, even though it might not be the full disorder, still has functional impact. Impact on how people see themselves or they are seen by others. Also, biologically, there is still something ongoing, and when there's then a life event, people spill over into the illness much more easily. So you see low remission rates are associated with poorer functional outcome and higher recurrence. We know that also from the STAR-D study, but there's also a higher odds of doing well when you treat it all the way. Better response and remission, shorter time to it, higher rates of normal functioning, which is what patients want. They want to function and their family members want that. And it might also happen earlier. So focusing not just on symptoms, but also putting the functioning up on top when we discuss the treatment options and make sure that people understand how important adherence is very important in our treatment algorithm. If we have a goal and the patient has a different goal, it doesn't work. We need to make their goals the goals that map onto the treatment effect. So early optimized treatment, EOT would be the short form of it, is very important. Getting the job done quickly and fully. And you all most likely have had the same experiences as I and many people across the globe, that the 75% of antidepressants that are prescribed, not by us, not by specialists, they're prescribed by primary care doctors, are often started too late, and then they are left at a very low dose, lingering. So patients have the side effect of the illness and of the medication, rather than trying to go all the way. And I think one of the biggest things we can do when we inherit these patients is to normalize that, yes, depression can happen, yes, we can do something about it, but we have to go all the way. When you have a tumor, we wouldn't excise only 3/4 of it or half of it. We need to go all the way. And depression is a tumor of the brain. We need to get it out. Yes, you might have some side effects when we go higher, but we can adjust that. And we can also change treatments. Most of these side effects are not permanent. And there might even be sexual side effects, and we need to address that proactively with patients because they may be ashamed to talk about it. And then they have other consequences in their life that might be negative. But as you know, depression is also a basket of different symptoms. So we need to understand which symptoms are relevant in this patient and for this patient. Some might not be bothered by, let's say, lying awake a little bit longer at night and having difficulties falling asleep. They can meditate. Others go crazy. They have bad thoughts and then the next day is shot because they have to get up and function. Others might be very worried that they can't enjoy anything anymore because their relationships suffer with their grandchildren, with their partner, with whoever. So it's important to know what matters. Being good at the job, being good as a mother, as a partner, whatever it is, so that we also focus on those aspects. I like measurement-based care, but it's often not doable time-wise. So either you give a scale out that they can do in the waiting room, the PHQ-9 or the Sheehan disability scale, whatever, or I use a very simple 0 to 10 visual analog scale. How depressed are you today? Or have you been in the last week? From 0 to 10. And then when they say nothing got better, and they say today it's a 7, well, a week ago you said it was an 8. Maybe there's a little bit that it's getting better. You just don't see it. Or your family member who brings you says something slightly different. They see a little bit more of a spark when you talk. We need to instill hope. Hope is already treatment. And relationship is already treatment, so that patients feel we care about them, how they do. That's also early optimized treatment. And then we need to obviously put together symptoms and side effects, symptoms and functioning. Significant functional impairment is not a good thing. both for the patient, the environment, society, but it also sets in motion a downward spiral. If I don't function as a mother or wife or father or husband, if I can't go to work, my self-worth will go down. And that then sets in motion inflammation, oxidative stress, cortisol release, and there's this biopsychosocial interaction. We are happy when we do things that matter to ourselves or others. And depression is very much in the way of that. So enabling people, even while they're still wounded with depression, to start doing something that's meaningful. And even if it's just taking a walk and activating themselves or talking to someone they like, can already be the beginning of improvement. And if we don't do that, then the recurrence rates, the past predicts the future, is set in motion. So going all the way, not accepting residual symptoms, and not waiting too long for maybe psychotherapy to work, or lying down and saying, I'm doing this because I can't get rest at home, that's maybe not enough. Yeah? So combining psychosocial and pharmacologic treatments early might be the best way to get out of the depression quickly, because the longer something lasts, the harder it is to get out of. We obviously have different symptom domains and think that they're related to certain neurotransmitters, but I mean, you see there are lots of overlap. All models are wrong, some are useful. Yes, adrenaline makes us wake up and be energetic, so if you have someone who's really very tired and anhedonic, maybe you need a little bit more dopamine or noradrenaline, so you go more into the SNRI camp. And if you have loss of pleasure, motivation, then you might go dopamine or serotonin, especially negative thoughts and obsessions. But overall, we know that SSRIs have been approved for many different conditions: anxiety disorders, PTSD, OCD, depression with seasonal affective disorder or component, whatever. So you can start with that. An SNRI is an SSRI at low doses. But when you then go higher, you will turn on the noradrenaline faucet. So let's talk about that turning on the noradrenaline faucet, venlafaxine. Venlafaxine is one of the approved and very much used and also known medications. Whenever you decide between treatments, you take into account the patient, the medication, and also the environment, whether it's reimbursable, whether it's available, and so forth, whether it's simple to use, whether you get to the doses relatively quickly where you want to be, and what are the differences in side effect profiles, as well as in evidence. In which patients have we had these data? Also, is there only acute or also long-term data? And we have all of this available for venlafaxine. It's approved for generalized anxiety disorder. There are data for amotivation and anhedonia, and I'll show you some new analyses on that. Fatigue gets better, somatic symptoms, as well as anxious distress. Now, when there are residual symptoms, we talked about it, that's not a good thing. It's the smoldering disease, and you can see that about 40% of patients with MDD have significant functional impairment, and that is associated with residual symptoms. Anhedonia, lack of energy, sleep disorders. Sleep and pain are two of our biological systems and also basic assessment areas we should always incorporate. It's not just heart rate and blood pressure and temperature, it's also sleep and pain. Those are our basic vital functions. And as psychiatrists, mental health professionals, we should always ask about those. Mental anxiety is more common even than depression and can set in motion some of these very negative thought processes that we've heard about. And then the disease course, obviously, relapses are more common when you have residual symptoms, because you can jump out of some illness easier to full illness than out of no illness left. Now, I mentioned that based on the dose, you're switching on different functions with venlafaxine. So at 75 to 150, you're clearly an SSRI, and then 150 and above, you become more and more noradrenergic. At the highest dose, the most, and maybe then you're switching even on some dopamine. So don't give up too early if patients do not fully respond and don't have rate-limiting side effects. I generally dose my medication based on two principles: wow or ow. Either I stop when the symptoms are done and the patient is doing well. Doesn't matter how high or low it is. It might be a slow metabolizer and I don't need to go high. Or if I have no wow, I go until I see the ow. So maybe this is a rapid metabolizer, ultra rapid metabolizer, and I can go higher unless they're not taking the medication. No side effects and no efficacy at high doses. I wonder what's coming through the mouth into the gut and then the brain. So non-adherence is always an intervening variable. And if nothing works that should work, not even a bit, and you don't have any side effects, then maybe have someone give the medication and supervise it in the environment. Now, anhedonia and amotivation are core experiential features of depression. We always talk about MDD as a global illness, but those are really core experiential features that are related to functioning and well-being a lot. There are now new measures, that the SHAPS, for example, that measure particularly anhedonia, but we can also construct different subscores based on the very well-known scores that we have. The MADRS 5 out of the 11 items can show you that there's some anhedonia based on apparent sadness, reported sadness, inability to feel lassitude, and concentration difficulty. So it's basically everything is down. Or when you look at the Hamilton Depression Rating Scale, it's work and activity levels that are problematic, general somatic symptoms, which is also lack of motivation, and motor retardation. And looking at these subscores on the very well-known rating scales, you can see that focusing on them rather than the total score, and it's harder to have less symptoms available to separate from placebo, but focusing on just those items, 5 on the left on the MADRS and 3 on the right for the HAM-D, there is significant improvement with venlafaxine over placebo, and it actually starts at week 2. So very early, there is something. It's obviously not the full effect yet, but people wake up out of this anhedonic, amotivational state. Again, you can maybe try to target this with different neurotransmitters. But we think that if you need more noradrenaline, then maybe you have to go with an SSRI and go to higher doses. So the treatment approaches include that we want to manage fatigue, and that was used also in pooled analyses to look at that. These data came from known studies, and now based on doses between 75 and 225, there was a pooled analysis done that hadn't been done before. And basically using a mixed models repeated measures analysis, even lassitude, which is something that really is the brake in the life system. Yeah? As if you're driving the whole time with having your brake tightened in the car, that lassitude was reduced with a significant effect, even as noted as early as week 3. And you can also see that there's basically an effect size that's medium, about 0.5, which is really something to write home about. We would see that as a mean. Obviously, there are some people that don't improve much and others have an even higher improvement. So this experiential part that silences life in people that have depression can be switched back on with a spark. And that is, in this case, due to Effexor-XR. And that's the timeline that you can see here, with the improvement on the left-hand side of energy improving and on the right-hand side of lassitude improving more than with placebo. There are also data comparing venlafaxine against SSRIs, particularly in people who may not do so well on SSRIs, and there was an advantage with a number needed to treat for response or remission of about 10. That's a 10% difference. So after each 10th patient, you would see one full responder more. That's basically 50% improvement over baseline. And compared to placebo, relapse prevention is huge. So looking at 44.8 versus 8%, the difference is greater than 33%. So that means the NNT is 3. After each third person that you continue on the treatment rather than stopping, you see 1 prevention of relapse. NNTs of single digit and below 5 are rare in medicine. So this is a real deal in patients that really need ongoing antidepressant treatment. And in my experience, and based on the data, it's mostly people who've had recurrent depression. And especially if there wasn't a life event that pushed them over the edge with a very long gap where they didn't have depression. But more frequent depressions that came without any external event, you may want to continue with the antidepressant. Or depression that was so severe that people really had a very long lag time until they regained functionality, or only partially regained it. Or when they were so suicidal that they actually tried to take their life. The past is the best predictor of the future. If they get depressed, why don't they do it again? And maybe this time they've learned how to do it better. So we need to obviously have shared decision-making, but ongoing treatment for people with 2 or at least when they have had 3 episodes is most likely what you should do. But functioning, as I mentioned, is very important. And here were some comparisons of Effexor versus bupropion, which obviously targets dopamine increase, with a fair comparison, 75 to 150 of Effexor versus 150 to 300. When you see comparisons, you always want to check whether it's preordained, the outcome, by giving a lower dose to the competitor and giving yourself the strong dose. But this was fair, and you can see, because you can go up to 450 of bupropion, that's basically 2/3, and you can go up to 225 or even 300 of Effexor XR, and that's about 2/3 to half of it. And you can see that always numerically and also sometimes statistically, Effexor was superior for functionality. Now here is a case that I brought to you, one of 2 cases, just to illustrate how important it is to go all the way and not just partial response. So this was a 42-year-old female, had overweight, BMI status, non-smoker, some physical problem, rheumatoid arthritis, working as a secretary, she's married, no children, and had a first depressive episode early on in her life, age 21, when she had a tough breakup from her then boyfriend that cleared up over 4 months just with psychotherapy and some support of fluoxetine 20 milligrams. She was doing okay until she had another life event, another loss. Not the boyfriend, this time it was the mother. She died rather acutely without any forewarning that this patient could have slowly gotten adjusted to and saying bye-bye to her mother. So it happened and was basically torn out of her life. And she became quite depressed, treated again with psychotherapy and fluoxetine, worked in the past. Why not now? Well, but it didn't. She was older, it was maybe a bigger gap and hole torn into her psyche and her life. Her mother was very important to her. And so she had some initial partial response. Her rheumatologist treated her initially, but she had residual anhedonia, amotivation, lots of pain symptoms, which may not have been the rheumatoid arthritis, but rather the depression, fatigue, and also became suicidal. Unable to work, felt stuck at home, increasingly worthless, guilt, thoughts, and conflicts with her husband, who actually depended also on her help at home due to her minimal activity, and had constant ruminations and complaints. So she had self-referral, she wasn't happy with her rheumatologist and felt she needed someone else, and then came the fluoxetine was first increased from 20 to 40, because if you have partial response or non-response to something, why not increase the dose? Didn't really help. So maybe another approach was needed, especially with the anhedonia, amotivation, and fatigue. We felt venlafaxine might be the good option, and it had to also go to be titrated up to all the way to 225 to get really enough of the juice of the noradrenergic targeting. So at 150, more in the serotonin realm, she became a little bit more hedonically driven, less fatigued, less feelings of guilt and ruminations. Sleep improved, but she was clearly not there yet. But then at the highest dose, she became much better, motivation and energy level much improved. So to the degree that she was able to even start at least part-time work again as a secretary, so she felt equipped enough. Her self-esteem went up, and also the relationship subsequently with her husband improved, which all hangs together, obviously. And she's now more hopeful at that point for a future that she could master what was before that insurmountable panic-ridden activities. I have to clean the house. I can't do that. And not bothered by pain, so she didn't need any adjustment in her rheumatoid arthritis treatment, and basically felt content again and could even see ahead for the future. Let's shift gears and talk briefly about an SSRI, in this case, sertraline. It's one of the treatments that's approved, obviously, and efficacious in many treatment trials and also in the recommendations. Response rates range between 50 and 75%. And we have, again, to consider patient factors, medication factors. Sertraline, in my opinion, has both the plus and the minus of having a very big dose range. And when you want to go very carefully in people who have anxiety disorders or even bipolar depression, I like to use very small steps. I can even start with 12.5 and then go 25, 37.5, but I can go up to 200 for MDD and even 300 for OCD. So this optimization and personalization is what I really like. Sometimes it takes longer to get there, so that's why maybe sometimes people don't like so much sertraline, but I think it's a very good option. And it's a good option in patients who need smaller dose changes. Elderly, those with comorbidities, those with co-medications, and that's often the case in the elderly and in patients that have other medications on board. So there are clinical data for anxious distress, melancholic features, seasonal patterns, atypical features, and in meta-analyses, sertraline comes up among the more powerful drugs. That's one of these meta-analyses by Andrea Cipriani. And there are also data going in the long term in patients who had responded to either CBT or sertraline. About half of the patients were in that camp and were then followed long term. And when you look at the long-term outcome, those that were actually continued on sertraline had a better, significantly better outcome than those that continued on CBT. So maybe it's a self-selection. Those that needed an SSRI would also need it longer term. But we have good data in people with comorbid physical disorders, and it goes both ways, correct? You have physical disorders that come with depression, and depression come with physical disorders. We just published last month in JAMA Psychiatry a meta-analysis of antidepressants for people with physical disease and comorbid depression, and they also work in those folks. But we need to make sure that there are not undue side effects. And here you see that basically there was an unstable angina and myocardial infarction patients in the SAD heart study, good effects and safety, cardiac safety for Zoloft. Also, post-MI, the same was found, that variables that can predict poorer cardiovascular outcomes, that's a narrow heart rate variability. That means you have not a good balance between the adrenaline and the sympathomimetic and vagal tone. So you want good heart rate variability, and that was restored and increased with sertraline. And you also want platelet factors to go down so that you don't have the accumulation of an atheroma that then bursts and becomes another nidus for a heart attack. So these two factors that would predict future MI, myocardial infarction, were actually improved with sertraline. And I'm bringing you here another case. This was a 64-year-old male, already obese, also a smoker, type 2 diabetes, on metformin, arterial hypertension on an ACE inhibitor, and hypercholesterolemia on a statin. So he has metabolic syndrome big time, and doesn't stop smoking. I mean, we see that irrationality quite a bit in patients. He had a prior heart attack, retired accountant, married 2 children, 1 grandchild. And his first depressive episode, which is not uncommon, happened when he was taken out of his usual self-reinforcing life environment. And that was working. That gave him stability. He had retired and felt somewhat worthless. So that also came with panic attacks, not feeling able to deal with the overwhelming emptiness that came with this change from work to no work. Initial insomnia, marked depressed mood, difficulties in concentrating, easily aggravated, and he also compensated by overeating, which is not good. He already has metabolic syndrome. That was like comfort eating, and easily fatigued and moderate anhedonia. So he's brought by his wife, who feels, oh my God, I'm losing my husband, what's going on? Bring him back to life. And he doesn't want to talk, so he doesn't go into psychotherapy, also not uncommon, correct? So we need to go right into the pharmacologic treatment. Sertraline is here chosen because of his multiple comorbidities and the safety that has been established for sertraline in those patients. And then the patient was titrated slowly in 25 milligram steps to 125, had some initial anxiety increase. Sometimes we see that when there's not enough serotonin, then these receptors are upregulated and hungry, and they can be then stimulated by this SSRI effect, or the patient feeling anxious, what will this medication do with me? Could also be psychological, but he was able to sail through it. We were able to calm him down and assure him this will go away. Some headache initially, but also went away. And then he really improved. Yeah? So his depression ratings went down, the anhedonia ratings went down, and especially he slept better again with less ruminations, which again helped him do far better. So what are the take-home messages? And we're right on time again. MDD is one of the most common mental disorders. As you know, it's bread and butter for us, but it shouldn't be bread and butter for our patients. They need to get this out of their lives because it's associated with a lot of burden, functional illness, symptoms, and comorbidities that can then also be set in motion with this vulnerability of depression. We need to have early optimized treatments to really nip it in the bud, get there all the way, and not be too tacit and let it smolder, as many of our non-psychiatric colleagues do. Treatments should be tailored to the individual symptoms, needs, patient situation, but also side effects, vulnerability, and both Effexor and Zoloft have been shown to be efficacious in many patients with these disorders. So I thank you.